Hello, everyone. I'm Dr. Ina Park. I'm a professor at the University of California, San Francisco School of Medicine, the medical director of the California Prevention Training Center, and the medical consultant at the CDC Division of STD Prevention. And today we're talking about improving chlamydia screening rates through opt-out screening, which is a sort of new method for screening, which is different than our risk-based screening that we've done in the past. So our learning objectives for today, we're going to identify chlamydia screening guidelines for different populations. And of course, I'm going to introduce the usual risk-based screening strategy that we've used before, and we're going to compare it to an opt-out approach. And we'll describe the benefits and challenges of using this type of strategy for an adolescent patient population. And then finally, at the end, we're going to show a video that uses language that might normalize chlamydia screening and demonstrate to you how you might make it a routine part of your clinical practice and care. So I just wanted to let you know about all the contributors, the planners for this event, as well as the faculty and our disclosures. None of us have anything to disclose at this time. And the commercial disclosure is that this activity is supported by an educational grant to the American Sexual Health Association from Hologic Incorporated. So to claim CME credit or CNE nursing credit, please view the entire webinar. Visit the link displayed alongside the webinar to take the post-test and complete your evaluation, and then you'll be able to claim your credit. Here's our roadmap for where we're going today. We're going to talk about chlamydia epidemiology, including what happened with chlamydia during the pandemic, because I'm sure many of you are curious. We're also going to talk about the national screening recommendations and just to highlight some new recommendations that came out just in July of 2021 by the CDC. We're also going to talk about screening trends in different care settings, because I think you'll find it interesting to see, what proportion of people are actually being screened in clinical care. And then we're going to launch into the meat of this presentation, which is looking at risk-based screening versus opt-out screening. So we're going to talk about the rationale, and we're going to talk about considerations for opt-out among adolescents and young adults. And then we're going to show a little bit of an older study on cost effectiveness modeling, but we'll show you how that sparked actually multiple real world efforts to try to improve chlamydia screening using this model. And then additional sort of previews or teasers of different studies that are going on actually looking at enhanced or opt-out screening, some of which are not yet published and some of which are already in the literature. Okay, so let's launch into the epidemiology first. This is just looking at chlamydia rates of reported cases among females aged 15 to 44 years and looking by different age group breakdowns in the United States. This is CDC data from 2010 to 2019. And so you'll wonder, well, we're in 2022. And the thing is that a lot of this data does lag behind because of delays in reporting. And then it takes a while for the data to be analyzed. And then over on the right side, you'll see I've designated the percent change from 2015 to 2019. And so the first thing I want you all to notice here is that it's just all going up, right? If we look from 2010 to 2019, we've seen, a gradual and steady increase up for all the different populations, regardless of age. And you'll see if you look on the right here that your top lines are the 15 to 19-year-olds and the 20 to 24-year-olds. And they've had a pretty similar rate of increase in the past 5 years. So, 9 to 11%. And then if we look at women who are older from 25 to 44, there have been increases. And actually the greatest rises are in women over 35. But I do want to point out that, they're starting at a much lower rate of infection than your 15 to 24-year-olds. Okay, so what happened during the pandemic? Well, as you can imagine, there were stay-at-home orders in the first part of 2020, that first quarter, right? And so STD cases dropped dramatically. So what did we do? We stayed home. We were socially and sexually distancing. Lots of clinics closed their doors or said, we're only going to see people with symptoms and not do any more asymptomatic screening. And so as you can see, if you follow these three lines, which represent chlamydia in blue, gonorrhea in yellow, and syphilis in purple, you'll see that 2020 and 20 was looking to be actually a year with even greater rates in 2019. This gray dotted line represents what we would have expected in 2019 based on the older data. So in 2020, you'll see in the first part from January to March, the rates of all three reportable STIs was higher than 2019. Then when we got to April, we had a huge crash. So we had a 50% drop in chlamydia, a 71% drop in gonorrhea, and a 64% drop in syphilis in that second quarter of 2020. But STIs didn't go anywhere. And you can see that they all started to creep back up. And I don't know about you all, but in my practice, certainly we started seeing more and more patients saying, I held out for 3 months, I held out for 4 months, but I got back on my apps, I started dating again. And certainly after folks got vaccinated, we saw people sort of resuming their regular frequency of sexual activity. So by the time we got to the end of 2020, you can see that by December, gonorrhea and syphilis had actually exceeded the 2019 numbers, so we caught up and then some. And chlamydia was the only one that still actually lagged a little bit behind, because as you all remember, chlamydia is mostly asymptomatic, especially in cisgender women. So a lot of folks had not sort of resumed, robust screening programs until, the end of the year. Okay, so who should even be screened for chlamydia? I think that's a great thing to review before we launch into the different ways to screen. So for cisgender women, everybody under the age of 24 who's sexually active or equal to 24 years of age should be screened at least annually. And so, I get asked this question a lot. Well, what if my, patient is changing partners frequently? There's no reason why you can't, check more frequently. The only thing I would say is when someone has chlamydia, not to check before 3 or 4 weeks so you don't get a false positive from dead nucleic acid that's still hanging around. But when we talk about folks who should be screened just based on risk, we're really talking about folks over the age of 24. And so those risks, include people having multiple partners, or a partner who's engaging in sex with other partners, or folks that are, having sex in conjunction with drug use, risk factors such as that. And then in pregnancy, screening is recommended for all of those folks who are less than or equal to 24 years of age. But can I just say, please check with your state regulations, because, for example, in my state, screening is recommended regardless of age and pregnancy, and these are the national recommendations from CDC, and your state may differ, so please check with that. And the cause for celebration in this slide is this fourth bullet right here, which is that the CDC has now come out and said to consider rectal screening for cisgender women for chlamydia, and especially folks that are reporting a history of anal sex, and especially those young people in that age range of 15 to 24 years of age where we have lots of chlamydia around. So this is a new recommendation. Previously, only men who had sex with men were recommended for rectal screening. And so now this is something that you can consider, if you get a history of anal sex from someone who's a cisgender woman. So now MSM, or men who have sex with men, there's actually no change in this recommendation in the 2021 guidelines. It's still testing at least annually. I have lots of patients, especially those who are taking HIV pre-exposure prophylaxis, who are actually getting tested every 3 months, and that's totally appropriate. And then at the exposed sites, so for men of sex with men, that would be genital sites and rectal sites. Now you might be asking, well, what about the throat? Can't chlamydia happen there as well? And it certainly can. The issue is that chlamydia does not usually survive that well in the throat. And when we look at studies of men who have sex with men, there's a lot less chlamydia in the throat than there is, for example, gonorrhea. So there's not a national recommendation. You may actually have a bundled test, as we do in my clinic, where you get both and you can't really order one without the other, and that's completely fine. But the national recommendations are only for rectal and genital screening. Okay, so what about our men who have sex with women? The women who have sex with men are getting chlamydia from somewhere, right? Well, in terms of the cost effectiveness, it looks like really only high prevalence settings. So we're talking about, teen clinics or adolescent clinics. College health is another setting, corrections. And so if you know that the rate of chlamydia in your setting for, heterosexual men who have sex with women is over 3%, it's something you can consider to screen, all men who have sex with women in your setting. Family planning would be another one. And now this is a new sort of section that's more fleshed out than it's been in the past for your transgender and gender diverse people who are your patients. What should you do for screening? So I do actually recommend that all of you go and look at this section in the STI treatment guidelines, because the screening is going to be, the same for a transgender, gender diverse person if the cervix is present. And so you can do, a urine test, you can do a cervical swab or a vaginal swab, depending on what other types of exams are needed. And if you have a transgender or gender diverse person who is having sex with MSM or other transgender women, then the screening recommendations are the same as for cisgender MSM. So we're going to be testing at least annually, and some folks as often as quarterly. Okay, and what about another group that should always universally be screened for chlamydia? Well, those are your people that should get re-screened after their diagnosis and treatment. So that's really all patients regardless of gender at about 3 months after they get treated, okay? And let's say they come in, 6 weeks after their chlamydia diagnosis because they bumped their, they have an ingrown toenail or something like that. It's fine to repeat screening. I don't think that you should do it earlier than a month because, again, we don't want to get a false positive result. And so, but, let's say they come in 6 months later, again, really any sort of time for opportunistic re-screening is okay. So despite all these recommendations, we've had national recommendations for chlamydia screening as long as I've been around, which is about 15 years, and even before then. The percentage of high school students who've actually, say they've been tested for sexually transmitted infections during the past year is really not that high. So this is the Youth Risk Behavioral Survey from 2019. And, it's done among high school students, and the total reported rates of chlamydia screening or STD screening is about 8.6%. Now, remember, not all of these folks are going to be sexually active, and we're actually going to go over those statistics for rates of sexual activity in the Youth Risk Behavioral Survey, but just wanted to show that there is a little bit of a difference by gender, with females, cis females, more likely to report screening. And then there are some differences by race and ethnicity, with Black students actually more likely to report screening than white or Hispanic counterparts. So as you can see, we're not doing a great job in screening our youth. So what about actually sexually active women who are insured? So this is the Healthcare Effectiveness Data Information Set, and it's looking at insured women and chlamydia screening rates from 2011 to 2020. And you can see, just to orient you to this slide, that folks that are commercially insured are in the blue and orange lines. And then folks that have Medicaid are in the gray and yellow lines. And you can see that it's divided up between folks that are 16 to 20 years of age and folks that are 21 to 24 years of age. So the general trend that we see here is that, first of all, none of these are 100%, right? And these are all sexually active women, and they're determined to be sexually active, through a sort of complex kind of chart reviews slash, pulling of codes that are consistent with sexual activity, like contraception codes, for example. So none of these reach 100%. You'll see that Medicaid actually has higher screening rates than commercially insured people, but nobody gets above 70%, regardless of age and regardless of insurance status. And the folks that are doing the worst is our commercially insured young people from 16 to 20 years of age. So those women, between 40-ish to 48% of folks are actually getting screened annually. So my point is we have a long way to go and we could definitely improve. And then the last thing on the slide I wanted to point out is that you see that everything took a dip here in 2020, which is sort of what we saw earlier with the national data in terms of reporting. Okay, so what about family planning? Do Title X family planning clinics do better? Well, not necessarily, but let me orient you here to this slide. This is actually looking at both the number of family planning users who are less than 25 years of age who got tested for chlamydia, and the proportion of folks that, so it's the number of visits as well as the proportion that were actually tested, right? So the hollow sort of bar chart here actually looks at the number of female users who were tested, in the system for anything, and the proportion of the users that were tested. And you'll see in 2020, there was a huge drop. In 2010, we had 1.44 million folks in the system and then tested in the system, and then 0.26 by 2020. And you'll see that there is the proportion of folks, varied between 52 to 60%. But again, we never get anywhere close to 100%. And in fact, the proportion tested here in family planning was actually lower than we saw for example, in Medicaid. Okay, so I hope I've convinced you that we're not doing a great job screening for chlamydia. And so what might we do to remedy that? And we previously used risk-based screening, which I think all of you are familiar with, which is where we take a sexual history. If the person is having sex, if they're doing any sort of activity that will put them at risk for chlamydia, then us as providers will order the test. And it could be augmented by saying, well, everybody, walks in the door and pees in a cup. Or we might have standing orders for some folks to say, we're going to do, a chlamydia test every year. But risk-based screening still is dependent on a provider really taking a sexual history and eventually checking the box, which, sort of checking the box to order the test. So I want to introduce to you a new concept called opt-out screening. So for opt-out screening, there is no sexual history taken. And I know that that's going to be, sort of disconcerting for some of us who work in sexual health, but this is really, a method to streamline screening and acknowledging that we're not great at always taking sexual history, especially when we're busy. And so no sexual history has to be taken, and there would be standing orders to screen age-eligible patients with a cervix between the ages of 15 to 24. And that would involve typically universal urine collection. And really all patients with a cervix are eligible for screening unless they have already had a negative chlamydia test documented within the past 12 months, or they refuse testing. So now I'm here to convince you and make a case for opt-out screening and why it could work. And so the first thing is that adolescents have sex. And those of you who are parents of teens probably know this. And if they're not having sex, at least they're interested in it. I want to start again with the Youth Risk Behavior Survey data, which is looking at the percentage of high school students who say they've ever had sex. And so interestingly, from 2009 to 2019, you'll see this percentage has declined. So for folks who identify as male, the percentage has declined from 46% to 39%. Meanwhile, for females, it's almost the same, 45.7%, and has declined to 37.6%. So we still have over a third of our high school students who say that they have had sex, but that has declined in the past 10 years. And when we look at sexual behavior with opposite sex partners, so this is actually from a different survey. So it's not the Youth Risk Behavior Survey. It's actually the National Survey of Family Growth, but it's looking at, very similar age range of students. And so if we look at people who identify as female, who report sexual behavior with an opposite sex partner, you'll see it's, pretty similar. We had a third, 39% or so reporting that in the Youth Risk Behavioral Survey. When we look at women and we expand it to any sexual experience, it's about 54%, with about 41% reporting vaginal sex, 44% reporting oral sex, and 9% reporting anal sex. And then if we look at folks that identify as just cisgender males, we have about half who say they've had any sexual experience, and actually less reporting vaginal sex than the females, less reporting oral sex, and more reporting anal sex. And that's interesting because, I'm going to show you as well data for same-sex partners as well, but males are reporting more anal sex than females are. And so the National Survey of Family Growth also looked at sexual behavior with same-sex partners. So you're going to notice, well, this is broken down, with less granularity than the last data, and it's true. They really only asked if you've had any type of sexual experience and didn't really go into a lot of detail about that. So when we look at that, though, about 15% of cisgender girls or women reported any sexual experience with someone of the same sex, and about 3% of cisgender boys or men. Okay, so I hope I convinced you that teens have sex, right? And now I want to make the case for opt-out screening to say providers don't take a sexual history. And I'm going to implicate myself in this as well. So I'm a family physician by training, and I also work in a sexual health clinic. In a sexual health clinic, we are very good at taking sexual history because everybody receives that, and that's really the only history they receive. But when you're in a family medicine setting, you're actually trying to manage, a whole list of problems, and sometimes sexual health doesn't necessarily get prioritized. And so I also want to say for your adolescent visits, sometimes there's a lot of other stuff going on, and sexual history doesn't always get documented. So I want to point out, some great work from the Children's Hospital of Philadelphia network. 31 clinics here by Pickle et al. And they actually looked at over 1,000 teen visits for 15 and 19-year-olds. And about a third had sexual history documented. Now you're thinking, oh, well, I ask and I don't always write it down. And that's true. But I'm just saying in terms of documentation, only a third actually had something documented. And your older adolescents, so your 17 to 19-year-olds were 1.5 times more likely to have something documented. And then some of these clinics also qualified as Title X family planning clinics. And those clinics, in those clinics, it was 11 times more likely that you'd have a sexual history taken, which I think makes a lot of sense. And then, of course, out of those 1,000 or so folks, about 13% had a GCCT, so gonorrhea, chlamydia screening test performed. And among those that were sexually active, only 9% were screened for chlamydia in a suburban clinic. And then when you get to an urban Title X clinic, the rates go as high as 73 to 77%. So you can see there's an enormous range, right, in terms of how likely you are to get screened for chlamydia, depending on the setting in which you are actually getting your clinical care. And the test positivity overall was 13%, which, by the way, is incredibly high in my world. Anything higher than 3%, we say, okay, that's pretty high prevalence. So 13% is very high. Okay, so we all know that, adolescents don't get hospitalized very often, right? Hopefully, they don't have any serious illness or reason to end up in the hospital. But for those that are hospitalized, hospitalization actually offers an opportunity to offer preventive services that you might not actually be able to offer because many teens don't come in for regular visits. So they're sort of a captive audience when they're in the hospital. And so among hospitalized teens, there was actually a survey done, and 37% of them actually wanted to have STI testing when they were in the hospital for a completely different reason. And actually, over half of them wished that someone had actually talked with them about contraception, during their hospital stay. So I thought that was really interesting, actually, that's actually, even though they're dealing with a completely unrelated issue, that, sexual health is still sort of front and center in their minds. And then, want to look at another analysis as well, another study done now with a smaller sample size than our Philadelphia study among patients, 165 patients who were over the age of 11, and another study looking at over 700 patients who are between the ages of 14 to 18 years of age. So again, a huge variability in the percent that had sexual history documented. You can see here 25 to 62%. And another, again, a huge range between a third to 70% of females and 14 to 44% of males. And I think the take home point here is that sexual history is more likely to be documented for folks who identify as female than it is for folks who identify as male. And again, in a similar theme to what we saw before, your older teens are more likely to have documentation of sexual activity. And among those who had the questions documented, 50 to 58% were sexually active. So if you ask, you will find out information. So I think that's the important point here. And so, as we've said, chlamydia is really common. It's increasing. We don't do a great job in taking sexual history. So our risk-based screening has not really led to very high screening rates in many settings. And so I think the question that we ask ourselves is, well, can we try something different? And could this sort of opt-out screening method actually work in my practice? So here's some challenges in opt-out chlamydia screening with teens. And I'm just laughing because this is the exact hand gesture that my son makes whenever I talk to him about sex, which is like, don't talk to me, I can't hear you, stop talking. So one of the challenges is that a larger proportion of teens are not going to be sexually experienced, right? So your younger teens, like your 13 to 14-year-olds, do you want to implement opt-out screening when you know many of them are not going to be sexually experienced yet? And, how do we justify ordering an STI test if a patient actually denies sexual activity? Should we not include opt-out because we're, wasting resources and time on folks that don't actually have sexual activity? And, are we saying we don't trust you, to report your sexual history, even though we know some people don't feel comfortable being completely honest with their provider? Also, it's great to take a sexual history because you need to know if they need contraception, if there's someone who could become pregnant. And then the other thing is that teens have to understand that sometimes there is a potential for disclosure through billing. So those explanation of benefits can sometimes come to their parents. And I've absolutely received angry calls from parents saying, how dare you test my teen? They're not having sex, because the teen has not disclosed, their sexual activity to their parents. And so will providers feel okay with this or not? So another option, which you can sort of entertain, which is a little bit different than a, complete sort of opt-out approach, is doing standing orders. And so that approach would be having folks collect universal urine collection when they register, regardless of the reason for visit. And then you can change your office systems in terms of, documentation in the EMR to permit a confidential sexual history. and training your nurses and MAs to actually ask that sexual history so that that happens before the provider actually enters the room. And then have them as well talk about the potential disclosure through billing, and they would check when the last chlamydia test is done, and document a contact number if the test is positive, and then of course discussing pregnancy intention, because you can't just stop at STI testing. So that's one approach. But I also want to go over with you a modeling study, that's a few years old now, but it's really the only, I did a sort of thorough look for other modeling studies, and this is really the only game in town at this point. And it's really looking at whether or not chlamydia opt-out testing could be cost effective. And that's really on a sort of national scale and not just like in an individual practice. So when we do any kind of modeling, we have to, make various assumptions, right, that go into the model. So the first is, how much insurance coverage would we have in the population? And then which percentage are actually going to utilize healthcare? And then this is an important one, the second bullet, which proportion of people would actually accept opt-out screening? So if you were to tell a patient, this is something we do in our practice, if you have 50% of the people saying, well, I refuse to have that done, then this is really going to change the effectiveness of this particular model. But the other thing we look at is, how well are you testing to begin with, right? So if you're using a risk-based method and your screening rates for your young people are 80%, well, then, you probably don't have that much to gain from opt-out testing. But let's say in this particular model, they estimated, or, their baseline testing coverage was estimated to be 30%. And they also estimated that this would increase to 55% with an opt-out testing model. And this is also assuming a baseline chlamydia prevalence of 0.8 to 5.8% in the population. And remember, of course, your practice might be different. One of those studies we looked at actually had 13% test positivity or prevalence. But let's just assume this is looking at a big population with a prevalence of 0.8 to 5.8% for chlamydia. And then here are some factors that could reduce the cost savings of doing an opt-out model. So we know that this happens, right? People get reinfected by untreated partners all the time, right? So if we have a lot of reinfection, that's going to overestimate the benefit of screening. If there's a highly sexually active individual and they're less likely to be insured on a population level, and they're less likely to utilize care, that's going to affect this model. And again, as I mentioned, if you are already doing great with higher screening coverage than was used in this model, and you can't actually do any better, you know what I mean, by doing an opt-out model, then you don't really need to bother with this. But most of us, I would say, and many practices are certainly, not even at 55%. So here are the results of that study. And you can see, if we have a, varying prevalence over here on the very left, looking at, 3.98 to 6.37% prevalence. If we do the traditional risk-based screening, you can see the dip in overall prevalence for each population. So the total dip would be from 5.17 to 2.69 if we do a risk-based model, with females starting actually higher with the amount of prevalence of chlamydia, and so dipping down from 6 to 3%, and for males from about 4% to 2%. So if we decided to actually go with an opt-out model, then we're actually going to reduce, hopefully, the prevalence of chlamydia from 3.2% to 1.4%, and for males from 2.2% to 1%. So you can see you get, an incremental, improvement when you replace your status quo screening, which is risk-based, with opt-out testing. So you'll also notice that for this graph, the scale actually goes from 90 to 200 years. It doesn't need to take that long. This is just, a very long sort of time span that was put into this model. Okay, now I want to tell you some exciting things that are happening in the universe of opt-out or enhanced chlamydia screening. And I actually gave a very similar talk to this several years ago, and there's been so much happening with different practices actually really taking this on as quality improvement initiatives. So I'm really excited to share this part with you. So I want to tell you about, one particular intervention, again, in Philadelphia. They're really into chlamydia there, I guess. They ended up doing a QI intervention for cis females 15 to 19. And so what they did is they opened up a sexual health encounter and then a well visit for all patients. And they actually did universal urine collection. And they ordered, but they did actually do sexual history. So this is not an opt-out. This is just a quality improvement intervention. And so they ordered chlamydia if the patient was sexually active. And then they had, those fun pop-ups that we all love on the EHR actually prompting, hey, does this person need a chlamydia test? So pre-intervention, their chlamydia screening rate was in the 40% range. And then post-intervention, their rate actually went up to 50%. And so, their chlamydia test positivity was stable at about 11%. And so again, very high prevalence of chlamydia. And I think one of the important sort of balancing measures that we look at with a QI intervention is this going to take me more time? Or does this take more time for the patient, as they go through the system and the clinic flow? And there was not a significant change in the median visit length. So that is something that you can say, well, that's something I might be able to adopt in my practice because it's not going to slow us down. It does actually improve screening rates. So another intervention, which was, an interesting twist on this, another QI intervention at a federally qualified health center in San Francisco, a slightly older age range of females in primary and urgent care from 16 to 24 years of age. So they actually had in the primary care and urgent care practice, actually everybody collect universal urine regardless of gender. But this QI intervention was really only for cisgender folks. Cisgender women specifically. They did an extensive provider and staff education. And then, those of us who are providers who have to do maintenance of certification, they actually made an MOC activity so that anybody who was participating in the practice actually got credit for this, which is huge because as we know, that can take a lot of time. And for the residents, because this is a teaching clinic, they actually paid the residents a financial incentive of $2,500 to be the chlamydia QI champion. And I can tell you that based on resident salary, this is a lot of money and this would be very exciting if I were a resident. So, providers then told the patient we're doing universal STI testing, and the patient, of course, had an option to decline, and that was documented in the EHR. So this is sort of, this is called a QI run chart, and this demonstrates, when we look at time across the bottom, and then you look at screening rates across the left, and you'll see different time points with the blue arrows where they actually, introduced different interventions. So, they actually announced the project, at this particular time, you see with the first blue arrow, and then you'll see where they did the targeted provider outreach. Incentives were announced to the residents. Then they put up, whiteboard magnet reminders, and then they actually ended the incentives, and you can see their screening rates steadily climb. And then even 18 months and 30 months post-intervention, they had actually climbing rates of chlamydia screening. So pre-intervention, the rates were 29.2%. 18 months post, they went up to 61.5%. So an incredible increase, more than doubling. And then 30 months post, again, 71% screening. So they not only sustained the gains, but they actually improved upon them. So the denominator here, in terms of the number of patients seen for each of these time periods was between, very similar, 485 to 518. The test positivity rates were much lower actually in this practice than in the other practices we've seen, only 3%. And the total cost for the incentives was about $33,000. So as you can see, if you pay clinicians, if you pay the residents to be QI champions, they really ride the attending physicians, got them to do the right thing, and we had wonderful results here in this practice in San Francisco. And I also want to tell you, about, this is a teaser, basically, of a study that has been going on, for at least the past 4 years, and it's going to be presented actually this September at the CDC STD Prevention Conference. It's called the Stop STD Study, run by Harold Wiesenfeld at University of Pittsburgh. So this is, again, in Pennsylvania. I told you they love chlamydia. They're going to be conducting this particular study in OBGYN, family medicine, internal medicine, and pediatrics practices. They're randomizing practices to either do, an opt-out intervention or not. And basically females 16 to 24 years of age who haven't been screened for chlamydia are eligible. So they're going to get an alert in the EHR versus no alert. And then for the enhanced opt-out, the medical assistant is going to room a patient, receive an alert, and tell the patient we're doing opt-out STI screening. So unless the patient says, no, don't test me, then the medical assistant is going to pend the order in the EHR, and so no sexual history is going to be taken. Now, of course, the provider can come in and take one after the fact, but the order is already pended before the provider even gets in the room, and the order hopefully will get signed by the provider at the end of the visit. So they're going to look at screening rates and a pre and post comparison of testing rates. So I'm very excited about this study. I think it's going to be really interesting. So now we have about a 6.5 minute video here, which is going to sort of demonstrate to you how to talk with patients and parents about opt-out screening. How do you normalize this, right? Because this could be an interesting sort of concept, I think, for some patients and parents to kind of wrap their heads around. So if you would join me in looking at this video, I think there's some great examples here that you might be able to adopt into your own practice.
How do you talk to your young female patients about chlamydia testing?
Do you think you need to get tested for chlamydia today? We could test you for chlamydia today. Do you want to get tested? We recommend a test for chlamydia to everyone under 25. Let's test you today while you're here.
The way you talk to patients makes a real difference in the choices they make. Here we're going to look at examples of language you can use that normalizes testing and makes it a routine part of care. And for young women under 25, chlamydia testing should be routine. CDC, ACOG, the U.S. Preventive Services Task Force, the American Academy of Family Physicians, and the American Academy of Pediatrics all recommend annual chlamydia and gonorrhea screening for sexually active young women up to the age of 25. Are we testing all young women as recommended? Far from it. Current data show we're only testing about half of all young women. We're missing opportunities to test. So, how can we improve screening rates? One strategy is opt-out or universal testing. The goal is to test all young women ages 15 to 24 as part of routine care, as recommended by the guidelines. Let's look at this first scenario. Monica is a 21-year-old woman who's come in for a Depo-Provera shot. She doesn't have a record of being screened in the last 12 months. This is an opportunity that shouldn't be missed. Let's see some examples of normalizing language you can use.
So, it looks like you're here today for a depot shot. We recommend a test for chlamydia to everyone under 25. I'd like to do that today.
Oh, I don't know. Do I need to get tested?
We test everyone your age for chlamydia. It's very common in people your age and often doesn't have symptoms, so you may not even know you have it. That's why I recommend testing. Do you have questions or concerns?
Well, how does the testing go? Is it a blood test? I'm already getting one shot today.
We can do a simple urine test. We can use the sample that you already gave us if that's okay.
Okay, sure.
It can be as simple as that. By emphasizing the practice rather than the patient, you can reassure your patients that testing is routine. Just like the doctor says,
we test everyone your age for chlamydia.
This type of language lets the patient know that testing is routine and normal. Let's look at another example. In this case, Nicole, an 18-year-old woman, is in for a confirmation pregnancy test.
I don't see a recent chlamydia test on your chart. Have you been tested in the last year?
No, but is that necessary?
We actually ask all of our patients your age if they've been tested for chlamydia recently. That test should be done every year. I'd like to do that today. Do you have questions or concerns?
Yeah, why chlamydia, and why do you test everyone my age?
Chlamydia is very common in young women, and often you'll have no symptoms. But if it's left untreated, it can cause other health problems. By testing, we can make sure we keep you healthy.
Oh, okay, sure. That sounds fine.
This is why it's important to follow the screening guidelines. When chlamydia goes undetected and untreated, it can lead to other complications, including pelvic inflammatory disease, chronic pelvic pain, ectopic pregnancy, and infertility. The guidelines extend to female adolescents, starting at age 15. This means you may also be talking to parents about screening. By that age, however, a provider may be taking some time to talk to the adolescent patient alone during the visit. Let's look at how to discuss this with a parent of a teen patient named Chloe. First, you can explain the normal course for the visit.
So how our visits usually work is we'll spend some time talking together about Chloe's health history and any concerns that you or she might have, and then I will also spend some time alone with Chloe. At the end of the visit, we will all meet together again to clarify questions or follow-up plans.
Is that really necessary? I'm always with her.
Some parents may be resistant to this. Try introducing the concept of fostering self-responsibility and confidentiality. You can emphasize that this applies to all adolescents. It's not specific to their child.
At this age, it is developmentally appropriate for Chloe to start taking responsibility for her own health. And it's also our office policy that all patients do spend some time with the doctor alone.
You can also emphasize that you are a trusted source of information for their child.
I know that some kids don't feel comfortable sharing everything with their parents. I hope you feel good knowing that she has a responsible adult, her doctor, who she can talk to about any health questions.
Okay.
When talking about chlamydia screening with a parent, you can use the same type of normalizing language. Discuss testing as a routine part of preventative care.
We recommend routine screening, much the same way we recommend regular vision and hearing testing.
Again, normalizing language focuses on policy and practice, not the individual patient. There are many ways you can talk about screening that can make that focus clear.
Testing for chlamydia is simple. Let's test you today while you're here. To keep you healthy, I recommend testing for chlamydia. It's a common infection that usually has no symptoms. We encourage all of our patients to get tested.
As a provider, your recommendation carries real weight. Research shows patients rely on their providers and the recommendations that they make. You can normalize sexual health and preventative care when you talk to your patients. Look for more resources you can use at the website of the National Chlamydia Coalition at chlamydiacoalition.org.